is going to be a problem, very, very likely that this is going to help. So how do you deal with this type of situation, which is coming? It's coming down the pipe. And so this is black box medicine. And so what I want to do today is talk in basically three parts. First, I want to describe what black box medicine is, why we might think it's a useful thing, and how fast it's coming down the pike. Second, I want to talk about regulatory avenues and how FDA is likely to deal with it. And third, I want to talk about how it might present for clinicians and in terms in particular of liability and implementation. Am I sounding all right, by the way? It feels loud to me. Okay, cool. I will start with a disclaimer. Nobody has paid me anything for this, which is very sad. If you would like to pay me for this, I'd be delighted. Please send funds my way. But more importantly, although I will talk about liability things, I am not a practicing attorney, and I am definitely not your lawyer, so none of this is legal advice, and you'll see it's mostly hand-waving anyway. All right, so back to what black box medicine is. So the idea here is that black box medicine is basically the convergence of two developing trends in medical technology, the first one being medical big data, and the second one being machine learning and artificial intelligence. Now, all of you know about medical big data. Data is showing up everywhere, not only in electronic health records, but also in insurance claims databases, in pharmacy records, in fitness trackers, in the fact that patients just take snapshots of all the kind of stuff that they do throughout their daily life. And all of this theoretically can be lumped together and give us exciting, interesting things, which has been promised for a long time and is now maybe starting to happen. The second half of this is how we might start to draw more insights from those data, which is the idea of machine learning and artificial intelligence, and the fact that we have more complex and more sophisticated computer systems that can start to see deep and complicated patterns in the data that are too hard for us to see on our own, that don't fit the kind of standard, simple patterns that we're used to looking for. So why would we use machines to try to figure this out? And the basic answer is, as I just said, it's too hard. We can't quite get it yet. Biology, obviously, is insanely complicated. Medicine is insanely complicated. And a lot of the tools that we use, while fantastic tools, tend to simplify things a lot, right? Clinical trials tend to be relatively binary type things. It works or it doesn't, or it works and maybe here's some subgroup analysis, but they're not going to tell us here are the 4,000 different factors that are involved in this pathway to figure out whether or not it's working. Not to say that we can't keep progressing in that direction, but the idea of machine learning gives us something of a shortcut, which is to say, rather than trying to understand everything, which is going to take a long time, what if we can start to leverage some of those patterns because we trust machines to say, with a high degree of certainty, here's a pattern that's going on, and maybe, hopefully, here's something that I can predict, and here's something that I can do about it. So it's kind of a shortcut. It's the idea that this is faster, that this is cheaper, that this is enabling us to do stuff we wouldn't otherwise be able to do. Now, the essential challenge of this, though, the idea of machine learning in medicine, is that it's opaque, which is to say we don't know how it works. We don't really know what's going on. And so the analogy that I like to use is Google Images, right? So I assume, how many of you have used Google image search to find stuff? Right? So you go to Google image search and you type duck, right? Like, I want pictures of ducks. And so you type duck into Google image search, and it gives you thousands of pictures of ducks. And how does it know what a duck is, right? How would you tell a computer this is what a duck is? It's incredibly hard. How would you draw a set of rules that says these things are pictures of ducks, and all of these other things are pictures of things that aren't ducks? Impossible to imagine how you would draw a set of rules that would actually do a good job and distinguish ducks from, say, swans or from Oreos. But the computer does it really well, and the way it does that, it looks at tons of pictures of things that are like, yep, that's a duck. Other people have said those are ducks. Humans have said those are ducks. And lots of pictures of things that aren't ducks, and eventually the computer learns in a similar way, deliberately, to the way humans learn what's a duck and what's not a duck, and it gets pretty good at it. The challenge, though, is you can say, yeah, you're really good, computer, at picking out ducks from not ducks, but the computer can't tell you why. Just like you couldn't give the computer a set of rules, the computer can't give you a set of rules that it uses. Sometimes because it's too complex, ducts are this cluster of 5,000 dimensional space, not helpful, or because literally the computer doesn't know, and just the same way that someone can say, oh, I know that that's this type of tumor, I can't tell you why, but I know it because I've seen 1,000 of them before, and I know that's one. The computer similarly can say, I know that this is a duct, but I can't tell you why. And if you substitute duct for likelihood of a particular type of cancer, or likelihood that this particular image happens to be a cancerous lesion rather than something else, you've got black box medicine. So how do we deal with this opacity? So before I jump into that, I realized I want to talk about 4 different ways we might see this technology coming in rough order of how fast they're coming and how close they are. The first is kind of a special case, which is image analysis, closest to the ducts. The second is prognostics, predicting what's going to happen with a patient, then diagnostics, and then finally treatment recommendations. So image analysis is already here. We already have machine learning-based, non-transparent, opaque algorithms to do medical image analysis that are already in use by patients. And there are other ones, or by patients, maybe by doctors. There are other ones that are strongly developed and are close to being put into practice. So paper in Nature out this spring that there's an algorithm developed that can do as good a job as the average competent dermatologist at identifying a precancerous skin lesion. Similar paper, I don't remember where this one was, talking about IDing tumors on specific types of MRIs, as well as the average trained radiologist, equivalent performance levels, but obviously not explainable. There are apps that are available for download by patients or physicians now. There's one called Right Eye, which is designed to diagnose, or not diagnose, but at least potentially identify autism in very young children by measuring their eye movements and putting that through a machine learning algorithm to identify whether or not there's likely possibility of autism. There's one called BillyCam, which attempts to use machine learning to evaluate the skin tone of infants to predict jaundice. There is one called, what's the last one? Face2Gene, which looks at facial characteristics of, again, infants and attempts to use that to identify the presence of particular genetic disorders. All of these using machine learning algorithms to do the image analysis. So these are, if not here already, very much on the edge of being here. The second type of thing that's going to show up, I think, relatively soon is just the use of prognostics. Give me a bunch of information about a patient, and I'm going to predict how long the patient's going to live and when various things might happen, not to use it, but just to know it. Obviously, the stakes on that are a little bit lower. Then diagnostics, some of this is also happening. So Watson Oncology is the one that's been getting a bunch of play here. Although if you've noticed, its play has been going from, wow, this is amazing, IBM is solving lots of things, or at least IBM says so, to, wow, it seems like IBM's Watson is actually doing a terrible job and isn't succeeding at anything, according to lots of other people. But Watson is a system that takes in information about a patient and attempts to say what particular type of cancer that they have, and then offers recommendations. Another really interesting diagnosis algorithm that I think is not yet in place anywhere but is being developed is a trauma monitoring algorithm, where basically it continuously monitors vital signs of trauma patients and attempts to identify when a patient is likely to hemorrhage in much the same way that a trained nurse would if they're constantly monitoring the vital signs. But it turns out trained nurses are expensive and there aren't tons of them floating around and watching every patient all the time. But you can have an algorithm that watches every patient all the time and says, hey, this patient's about to crash, get here right now before they do. And then the last type is to say, okay, well, if we have all this information, can we use all these data to try to figure out what to do to improve and treat patients? So part of this is just the easiest version of this is, hey, when we're picking between things within the standard of care, which do we pick? Watson Oncology tries to do this. So they use machine learning to diagnose the cancer, and then at least they say that they offer you treatment recommendations. Now, it turns out that everybody thought that they were using machine learning and artificial intelligence to pick the treatment algorithm. Turns out they're not doing that at all. They just ID the cancer, and then they tell you what people at Memorial Sloan Kettering would do for that particular cancer. Still useful, but not quite what we're thinking about in terms of saying, hey, can we do more? Can we figure out things that we're not currently able to do with our current resources? So one thing is within the standard of care, then you can think about off-label uses, saying, hey, actually, here's a similar disease that this drug worked for, and I'm going to recommend it here, even though we haven't run trials, even though doctors aren't doing that yet. And then the last form is when we start getting really crazy stuff, the kind of thing like saying, I've seen patients in a totally different situation in my giant data set that have responded that when they get small doses of antipsychotic medicines because they're psychotic, don't develop ulcers in this situation when other patients do, so I'm going to recommend that you do this. Can't tell you exactly what it is about those patients, but it seems to work, so I'm going to recommend it. That's the farthest away. Okay, so this is the giant scheme, at least as I'm presenting it. Some of this stuff is really right around the corner, if not here, and some of this stuff is a ways out, as frankly it's been a ways out for a while, and we'll see how quickly that future comes towards us. Given this spectrum, though, I want to turn to part 2 of this talk, which is how do we regulate it? And how should FDA deal with this? After all, it's a new medical technology. What do regulators, or what should regulators do about this? So the first question I just want to spend a brief moment on is, should FDA do anything at all about it? Why would we regulate this? One possibility is to say, it's just some sort of good or technology. Why put it through FDA? The other possibility is to say, this looks just like the practice of medicine, which FDA doesn't regulate, so maybe it's just practice of medicine and not something FDA should touch. It will not surprise you to know that I think that's probably not the right approach. The reason that we want FDA to take a look at things, new medical technologies beforehand, is because medical technologies tend to be credence goods, right? So patients don't really know, doctors often don't know whether or not an intervention is going to help patients until we do things like clinical trials to figure out, yes, it actually works, right? This is a familiar concept to everybody, I assume. And so FDA tries to help develop that information so that we're convinced that things work. Here, it's even more urgent because we really don't know even how this stuff is supposed to work, right? We don't even have a mechanistic projection that says, oh, I think this drug's going to be good because it's going to impact this pathway that I understand. It's just, here's a bunch of data. I think I can help because I've got other data that say it seems like it should work. So it seems like there's some sort of role here, but the question is exactly what FDA should be doing. Now, FDA in general for medical devices, which is a huge, broad term, engages in various levels of pre-market review. And the most stringent of those is Class 3 medical devices, where FDA basically demands a full pre-market approval pathway, clinical trials, the works, similar to what you'd want for a new drug coming onto the market. Really expensive, really slow, just like new drugs. FDA has not talked a great deal explicitly about machine learning, but what it has said so far suggests that it's going to say that all black box algorithms that are used for treatment or diagnosis or that are used to inform those processes are likely to be Class 3 medical devices, which is to say anything that fits into this box is likely to require clinical trials, a full pre-market approval pathway, the slow, deliberate pace of approving a new high-risk medical device. Now, there's a challenge to this, right? Which is to say, a part of the point of black box medicine is that it lets us take shortcuts and that it lets us use things earlier before we understand them. It lets us incorporate new data about the world more quickly and put those into the machine learning kind of pot of data to continuously try to get better at this. And that just doesn't fit well at all with the idea that what you want to do is run a multi-year expensive clinical trial and get approval for a single product that's going to stay exactly as it is. So how do we do it better if it doesn't work to rely on a long, slow clinical trial process, if that's going to take a lot of the moxie out of black box medicine, it's the kind of point that we're developing it, how do we do it better? Well, I'm not quite sure. One possibility that I think is probably attractive is the idea that we want to try to leverage not only FDA's expertise as kind of a centralized regulator in the way that we do with drugs, but instead move towards a more collaborative system where we get input from different actors in the marketplace. And in particular, if we really want this stuff to be flexible and incorporating new information and developing as we get more data and saying, actually, no, it turns out antipsychotics are not at all helpful for ulcers. I recognize that I suggested those for you, and I was pretty certain, but now that I've seen it tried a few times, it's terrible, and let's not do that anymore. We want that information to go back into the system, and we want that to be evaluable not only by FDA through a kind of binary one and done process, but also through other people that are, or other actors that are sophisticated and know what's going on. So doctors, physician groups, other care providers, hospital systems, insurers, all of these potentially have a role to play in saying, is this actually working? How should we improve it? Is this algorithm high quality and this algorithm low quality? And how can we make this better? What's working? What's not working? Now, the challenge for that, of course, is that all the companies developing these things don't want to actually share this information, right? This is the kind of thing where you say, aha, I have the secret sauce. My algorithm is the best. I have the best data. I have the best algorithm. I will help you do everything, but I don't want to tell any of you what's in it. It's secrecy layered on top of opacity. So I think if we want a model that's really going to allow this sort of collaborative oversight and real-time feedback, we're going to need to get over the idea that the stuff that is kept secret should still be kept secret. Secrecy doesn't really work when you've got a technology which is fundamentally already opaque if you want to try to make that as good as possible. I don't know whether or not FDA is going to go for this. They have made some interesting noises along the direction that they're into collaborative governance. So back in June, they announced the Digital Health Initiative, where they're talking about using software apps and mobile health apps and mobile health governance and suggesting that they want to move towards this kind of lighter pre-approval with a heavier back-end post-market surveillance. They're interested in having third parties involved. A lot of buzzwords, and I'm curious as to whether or not that actually ends up happening in the real world. But it seems like they might be open to this approach, which I think is pretty exciting. So, part 3, how does this matter to all of you? Or, in other words, how does this work in terms of providers and caregivers and those associated with the healthcare system in terms of actually implementing this stuff in terms of both kind of liability concerns and implementation concerns? And once again, to reiterate, I am not providing any legal advice here, so they do. Wait, where are the general counsel people I saw? Yes, there we go. Talk to her, not to me. All right, so liability. Who is liable when this stuff goes wrong, as it inevitably will? The first place you might look is to developers, right? You might say, actually, let's not worry about clinicians. Let's focus on the people that are actually developing these algorithms and helping deploy them. Are they likely to be liable? And the answer, as you will see a couple of other times as I give this section of the talk, is pretty unclear. Turns out courts are not big on imposing liability on software developers for various reasons. They've managed to escape most of the time. And in this particular case, it's especially difficult to impose liability because of the doctrine of the learned intermediary, which essentially says we're not going to impose liability frequently, not always, but we're not going to impose as much liability on the people that develop new medical technology because doctors are the ones who know what's going on. Or doctors or nurses, excuse me. I'm so sorry, I got into that bad habit of just saying doctors, and I don't mean that. Caregivers, providers are the ones who know what's going on, and so this concept of learned intermediary applies to providers and says, providers know what's going on, and ultimately the final decision is theirs, and therefore we're not going to reach back and say, oh, you drug or device maker did this thing poorly, you didn't provide enough warning, because actually the caregiver right there in front of the patient is the one that made the final decision and that knows what's going on and is knowledgeable and an intermediary, so that's a block in the liability chain. Now, of course, the challenge when you apply this model to this type of medicine, to black box medicine, is the provider has no idea what's going on, right? Nobody does. That's the point. How can you know actually how the algorithm is working when literally nobody understands it because the machine learning mechanism doesn't provide any way to understand it? Now, you might argue that's a little bit facile, because while you don't understand exactly how the machine's making its decisions, you can understand how it was developed and how it was validated and how we put the data into it and made sure the data were high quality, and whether or not it's appropriate to apply this sort of algorithm to this sort of patient. And in that circumstance, that type of analysis, I think, is actually where we're going to step outside the learned intermediary and say that might be where the role is for providers, which is to say, we know that you can't understand exactly how this thing works because nobody does. But what you can do is say, I want to see indicia of quality to indicate that this was developed in whatever responsible fashion we decide is the best way to do this. This was developed via, people that have had a certain amount of experience in doing this. This is using data that are high quality and not just random garbage pulled in off the street. This has gone through whatever sets of validation. And so that seems like the kind of decision where we can say, actually, there should be a role here for providers, for hospitals, for insurers in saying the procedural aspects of this algorithm, those we can make sure those are high quality and those we should do. And so that's, I think, the most likely place where we could imagine liability for providers coming in, right? The duty of a provider to operate under the standard of care. You could imagine that including a duty of a provider to exercise due care in selecting the algorithms that are going to be used and potentially in following or not following the recommendation of those algorithms. Now, in my predictive hat, do I think this is likely anytime soon? No. The courts are not particularly good at using liability to regulate the development of medicine, and you can argue about whether that's a good or a bad thing, but the likelihood of a court saying, oh, you use this algorithm and you actually should have used this algorithm anytime in the near future does not seem particularly high. And maybe that's a bad thing. Maybe that's a good thing for everybody here, but a bad thing for society, in as much as it removes a potential tool to how do we actually bring this type of medicine into good, efficient, effective practice. And that's, I think, where we might imagine a role for the profession, other than through the court system, to try to make sure this works, which is to say, even if the courts aren't going to assert rules or create rules or develop rules that say providers have to do X, Y, and Z in terms of making sure that an algorithm is high quality, maybe that's the kind of thing that through ethical or association guidelines we should be thinking about to say, when you're a provider, when you start to see this type of stuff showing up because your hospital is saying, hey, we are developing a contract with IBM, and now they're really going full in on the machine learning, and now they really are saying, we're going to use all these data and these algorithms to both predict and diagnose, and then also to make treatment recommendations. What do we demand, or what should you demand, in terms of saying, yes, okay, this is something that I'm comfortable bringing into my practice. No, this is not something that I'm comfortable with. What should the hospital demand in terms of bringing in these particular products or not bringing them in? So that's one role I think we can see for providers here and for other entities in the health system, is demanding some sort of procedural validation for things before they enter into practice. The other thing is in the concept of, along the lines of early transition and how do we actually implement the decisions or the recommendations that an algorithm makes. I think, at least in the short term, we would probably want, and I suspect nobody here will disagree, we would probably want providers making decisions about whether or not to implement what the algorithm recommends, right? If they say you should pick this drug versus this other drug, then you would like providers to say, yes, that makes sense to me, I'm gonna go ahead and do it. It makes a lot of sense, particularly in the short term, in the transitional period as we're developing this, to say how risky is this intervention and to balance that across, or balance that with how convinced am I that this algorithm is really good. So in the standard of care stuff, that might be easy, right? You might say, okay, well, a patient comes in, they've got persistent chronic migraines. Here are a couple of different drugs I prescribe. It's something like a coin toss right now based on the patient's particular symptoms. I'll let an algorithm pick, and I'm not really worried about any additional risk from this because there's no particular reason to pick option A over option B right now. So I don't really care how good the algorithm is. I would like it to be good, but it doesn't make a huge difference how much I'm going to worry about that one in terms of putting in the recommendation. On the other hand, once you start to get to riskier and riskier interventions, things like saying, oh, you know, actually, that tumor looks like it might be aggressive, but it's indolent, so I'm going to recommend that you not worry about it. That might be the type of situation where you say, well, I'm going to demand a lot of validation for that. I want to be really sure that you're quite good about that because that could have serious consequences. And when it starts getting really crazy, like saying, I recognize that this woman is pregnant, and I recognize that she shows no symptoms at all of having this rare disease, and I recognize that I'm about to tell you to give her thalidomide, and you might say, that seems really crazy. And there we might say, at least in the current state of affairs, there is literally no amount of data that you can give me to convince me to go through with your recommendation. And so we can imagine that at the pointy end of the stick, when this is actually going into practice, we would want a spectrum of how convinced do I need to be of a particular intervention or of a particular algorithm's quality before I'm willing to go through with its recommendations. But I'll offer a caveat, which is this. If we're too careful about this, we leave a lot on the table. Right? You could imagine a situation in which algorithms are saying, do A, B, and C for all these people, and the only thing that you actually do is go through with it when it agrees with what you would have done anyway as a provider. And that's leaving innovation on the table. That's leaving health on the table, which is to say we're not really getting any new benefit out of this. It feels good. It's like, the computer's telling me to do something I already would have done. Look how smart I am. That's great. But it's not helping us treat patients in a way that we would have otherwise before, except maybe with some efficiency gains. And eventually, where this gets hard is when the algorithm starts saying, here's something you should do that you don't think you should have done. And you have to say, OK, I'm willing to trust it. I'm willing to do that. And the question of exactly how much you need to be able to make that leap and trust what they're saying, that's the tough question. How do we make sure that works? And so I'll close, and I recognize that I'm probably closing way shorter than most people do because I hope for lots of questions and discussions, but I'll close with a step backwards, which is to say, in the process of medical education, how well are we preparing new providers to be able to make this type of decision, to be able to understand what's coming down the path in terms of new medical technology, in terms of knowing how big data works, knowing how machine learning works, at least knowing enough to say, I know what questions to ask to know whether I should trust this or not. And then to take a step even further back, it strikes me, and this is me going out on a longer limb, it strikes me that this is squeezing the medical profession from a different direction that it's used to be squeezed? Squozing? Right, so on the one hand, you've got the role of the doctor in the middle. The doctor used to do absolutely everything, and now we've got laws that are saying actually people with different professional licenses should be practicing up to the limit of their license, should be doing lots more things. And now you're saying here's a different set of technologies which is coming in and saying actually the one thing that doctors are definitely the experts in, the one thing that they totally know is let's take in all these symptoms, let's take in all this data, all these years of training and apply them and say I know what you have and I know how you're going to treat it. We're going to say no, actually the algorithm's better than you at that. Right now, we have algorithms that perform as well as trained dermatologists, as well as trained radiologists. That's not going to last. They're going to get better. And so what happens when you say, OK, here's a technology that's actually doing better, squeezing in from this knowledge direction, and what is the best new role for doctors in this particular world? Now, I'm not a doctor. I don't know. My guess is that a place where algorithms really can't penetrate at all is taking in the things that are not just about the data, that are not just about the textbook symptoms, and here are the drugs that are available, but rather saying, how do we translate that with the particular set of risk preferences, desires, fears, hopes, needs, et cetera, of the patient before me, the kind of stuff that never can go into a big data calculation, and then how do I evaluate those risks with a different set of information that the algorithm won't know. And I frankly have no idea how physicians are being trained to deal with those sorts of issues, and it's possible the answer is awesomely. Everybody already knows exactly how to do this, and textbook medicine is a thing of the past, and Nicholson, you are operating under a vision of medicine that is 70 years old at least, in which case, hooray and awesome, but I don't know. And so frankly, I'd be curious to know what you have to say about that, as well as hopefully I am to hear what your questions are for me about this. With that, I will stop and take your questions, if you have any. Otherwise, this was short. Yeah, so it's an interesting nest of questions, right? It involves both how well the physician or the patient will, the patient's relationship with the physician, the patient's decision about whether or not to follow the particular treatment recommendation, the informed consent contours of this. Do you need to give a different type of informed consent if you're saying we're relying on this technology that we don't understand, and how much do you need to explain that? Or is that similar to saying, I'm going to prescribe you lithium, and we don't really know how lithium works very well, but we're pretty sure it does, so we're just going to go with that? And that, I think, is not a conversation that happens all the time. It's just, this is the lithium that we prescribe for bipolar, right? Right? Okay, cool. And even though we don't know how it works, we know it does, so we don't really talk about that. Similarly, you could say, I'm not really going to talk about this new thing. I think there's a challenge. This presents a challenge to the idea of physician as the one who knows everything and therefore makes all the decision and possesses all the expertise in the room. Now, that comes in the context of a bunch of other challenges to that. The shared decision model, the shared decision-making model is itself a broad challenge to the idea that the physician should be the one making all the decisions. And I don't know how it will interact with the idea of saying, either here's another challenge, or this is a recognition that we're in this together, and here's the stuff that I, as provider, can offer to you that you actually can't get through the algorithm and you can't get through anything else, but here is how I can help you think through this, and we do it together. I can see it actually fitting in pretty well with the shared decision-making model, which is to say, here's another input. I don't get it, nobody gets it. But working through that and exactly how much you have to be explicit about the fact that nobody gets it, and whether that's really going to help patients to be explicit about the fact that nobody gets it, is a subject for excellent future work. Yes?
So for me, this begs for science fiction, right? And thinking about ways that this can go wrong. And especially for a room with a lot of people who do clinical ethics consultation and think a lot about who should be dead and when. These are the calls we get. Is it this person's time or not, and who decides? And if you're imagining a process that's opaque and an electronic medical record that is vast, even if we say values-based decisions about what to do reside in the hearts and brains of medical care providers, do do we know that we can stop these systems from taking in inputs that we don't want them to, and saying, this is a convicted felon, this man is 98, things like that could play into decisions in ways that we never meant them to?
Yeah, so there's a fascinating literature on this in the context of policing as well. Like, policing is an area in which you're seeing these predictive algorithms coming into play. And what you find is that the predictive algorithms predict based on past data, right? And so if you're going to ask, where are the hotbeds of crime? Shocker, you'll find that the hotbeds of crime are minority neighborhoods. And it's not just because there may be crime there, but it's also because those are where the police show up a lot, and therefore those are where you see arrest records. And if what you're doing in your database is looking where you see arrest records and where you see reports of crime, you're going to get a tremendously skewed version of what's actually going into this database. And so that's a huge concern here as well, which is to say, what are the data that we're allowing the system to take in? And are there data that would be medically useful, but we don't want the system to be using because of the fact that we think that brings in troublesome ethical aspects? Like, if you were to say, well, I don't need to give examples because you can all think of them, and because I will probably get myself into trouble if I try to think of any particular examples on the fly. But yes, there are lots of troublesome data we could put into here. And it's hard because, again, you don't have an audit trail, right? You can't go in and say, how did it make this decision, and how would it make this decision differently if we hadn't included these data? The only way to kind of try to deal with that is to keep the really troublesome things out on the front end, but that's hard because you don't always know what's troublesome on the front end by itself, or because it's a proxy for something else that we really don't want to be relying on. So yes, nasty questions.
Really enjoyed your talk. So you talk a lot about the role of a clinician in interpreting these outcomes. Can you talk a little bit about when these technologies are marketed directly to patients or consumers, and the other issues that are brought up by that?
Yeah, I mean, so the app store, the combined app stores of, this shows up across medical technology, even if it's not algorithmically based. So the combined app stores for Algorithm and Apple have, I think, at last count, something like 196,000 medical apps. Obviously, a huge fraction of these are just total junk, like completely poor quality. There was an audit of, to take a somewhat simpler example than the stuff I'm talking about now, an audit of diabetes apps that recommended insulin dosages, and they were just all over the place. A huge fraction of the apps that were available did a terrible job in terms of just recommending insulin dosages. So how do we make sure that patients are doing this right? Partly, frankly, I think this is a big part of the reason that we want FDA to have a role in this in terms of regulation, which is to say it's too much of a Wild West out there right now. And there is a push for, or there has been a push for, we'd like to keep this marketplace quite open. We'd like to keep lots of innovation in this. Silicon Valley does not play well with Bethesda, and so we've left the gates pretty open so far. I think that's probably too open. I think, in particular, as these things become more powerful, as they start recommending weirder stuff, there's probably a role for FDA in trying to keep things off the market. It's hard to say exactly how that will work in terms of political pressure, because when FDA earlier on said, we'd like to regulate mobile health apps more, there was a huge backlash, and then they stepped backwards pretty quickly. And their current regulatory framework is a much lighter touch. Now, the framework that they're working with is a risk-based one. So they're saying when apps are doing things that look like diagnosis, when they're doing things that look like treatment, we're going to treat those as medical devices and apply more scrutiny, and I think that's probably the right thing to do. But in terms of here's something that's gone through and we've verified that it's good for providers, and now patients are also getting on their smartphones and saying, well, I should just go and combine these 7 OTC medicines because they're going to help with this problem that I haven't told a doctor about. Like, yeah, that's gonna be bad. Yes? So I'm not sure. So I can see two different versions of your questions, and I thought I was totally on track with you until like the last 7 words. When you said when the doctor-patient relationship goes sour. And I'm not sure whether, so I think there are two different things here. One is this causing a problem with doctor-patient relationships, and is this causing a problem inside the room? Versus is this causing a problem outside the room into patient health because it's a poor quality algorithm or whatever? I think those are rather different questions. On the first question, the problem inside the room with the relationship, I don't, sorry, am I, I don't see that as much having a kind of feedback function with the community saying, actually, this algorithm is recommending things that are problematic for the way that I interact with my patient, and that's something FDA would get involved in, because frankly, I don't see FDA being involved in that part of this. I don't think FDA sees its role, I don't see FDA's role as policing how doctors interact with their patients in terms of giving advice or informed consent or patients following the doctor's advice and all of those things. I think that's much more a conversation for inside the room and medical education and things like that, not so much the regulators. The second part of the question, though, is what about this ecosystem for providing feedback in general, and who has the incentive to provide this type of feedback and to really check on these things in terms of how well they function? And there I get to rah-rah for learning health systems, ELSI, and all of that stuff here, because I think the ideal version of this, the way we would want to see this working in 5 or 10 years, is that black box algorithms and big data in medicine fit into the context of a learning health system, and the process of saying this algorithm is working or this algorithm isn't working, and here are additional data that are needed to train this and make it better, all of that fits within the model of a learning health system. So we have that last step of care, which is measuring how well things go, collecting that data, and those data go right back into the black box, right back into the data set to say, okay, we did it pretty well this time, but let's do it better next time. And that doesn't just happen from providers and caregivers and hospitals and all the other elements of the learning health system, but it also happens in a separate loop through big data sets and algorithms, and saying, when I'm checking that EHR recommendation, it's including the data from the patients that my colleagues saw last week, and that's been already automatically incorporated into this algorithm. Ideally then, I think we also take those data about how well things worked, how well or how things didn't work, and what we could do better, and those also go out, maybe mediated by FDA, and are shared with the entities that are responsible for evaluation. So FDA and insurers and physician associations, and all of these are able to monitor and say, actually, this is doing really well. If I am incorporating this algorithm, if I'm looking to incorporate this algorithm at the University of Michigan, I would love to know that it's been used at the University of Virginia hospital system for the last 6 months, and these are the results that we've seen from that, and those data are incorporated every day because we have a learning health system that brings those new data in, and here's how it's getting better. I would love to know that, and I would love, as the UVA health system, to say, well, here's what my competitors are seeing, here's what everybody else is seeing. So I'd ideally like to see a robust system for this built into the idea of a learning health system. I think we're a ways off both on the black box thing and on the learning health side. I see this as an additional motivator for a learning health system, frankly, which is to say this technology is happening, and it's great if doctors can run clinical trials and pragmatic trials on what they're doing to figure out how to do it better. But if we're gonna have additional technology coming in, we'd really also like to have those data there. I don't know if that's a hand up or...
Hand up if there's nobody else.
Yes, go for it.
Just running with that. That sounds like an argument, whether, and I'm not a legal person, but it sounds like an argument for basically an accreditation process for the implementation of these types of algorithms, in which what is tracked is that you have implemented that feedback loop and made that group of data then available for tracking. We may not know what goes in, but we can
That's a great point. And that's something that I hadn't thought of before. In terms of saying, how do we want to make sure that as these systems are high quality, we could ask the earlier questions that I presented about what sort of data do you feed into it, what sort of validation do you do, what sort of techniques did you use to develop this algorithm. But a separate thing we might want to put it is, how have you already thought about and prepared the framework for a system where we're going to take these outcome data and feed them back in and make them available basically for auditing, so that others can help to evaluate this technology as it develops and as it's implemented. Yeah, I think that's a great point. I see the sounds in the room. I don't, yes, nope, okay. Yes.
So how do you keep pharma from how influencing this? I mean, hackers can rig an election. They can easily get inside the black box and make it so that we always drink Coke instead of Pepsi or whatever. If there's sort of, I mean, how does that work if the black box is truly opaque?
Yeah, so if you can't know how this stuff works, then how do you make sure that it's not being nastily influenced either by, oh, she's gone, either by data that we just don't want, that might be useful or truthful, but we don't want to be involved, or by nefarious actors who are getting involved that we very much don't want to be involved. It's a challenge because the normal ways we do this is to say, we're doing the clinical trials, we see how this works, et cetera. So we don't need to worry about that because we're showing that it truly, in fact, does work. And so I think the answer is probably along the lines that we've similarly talked about, which is, on the one hand, we want to be able to validate and say, look, it actually is working. We want to be able to do that in a rapid, real-time fashion so that we can, if things start going wrong, we catch them quickly. The other side of this is, I think there's an advantage to saying, this is going to be a market where we have a bunch of different people recommending things, a bunch of different developers. It's not just going to be Watson, right? So we have IBM, but we also have Apple and Google and small players in this and all of those things. So I think you can imagine a role for independent validation of, yeah, I get the same results as this, or, hey, actually my results are better and here's how I can demonstrate that they're better. So it might be naively optimistic to say that we would like to think that there's some market competition helping weed out the nefarious actors. I don't have a better solution for that other than, be secure, don't get hacked, which is not super comforting.
Sounds similar to the way we do now. I mean, if you see a big trial that shows some outcome, you look and see the front of the trial, and you take it with a grain of salt to other trials. So it sounds like similar.
I think so.
Numerous systems.
Yeah.
So we've been
Oh,
focusing.
wait, there was somebody I haven't seen before, and I know you.
I was just thinking along similar lines, but whether or not one would have some kind of system that identifies or filters for whether cost data is or isn't going to be used, because I can see that working in completely, potentially opposite directions between A, is it something that's going to be affordable for the patient over the long term, versus B, is the institution who's engaged in buying this black box using it to also circulate business, and how does that then get into concerns of self-referral or other forms of not looking at health but looking at business models?
Yeah, so completely agreed. So part of the other challenge in this is when it's opaque and how do you pick which values are worth putting in? So cost is something that I, as somebody who teaches health law and thinks about overall systemic costs, say like, yes, that's clearly great if we have the option between something that's cheaper and something that's more expensive. I'm not really concerned if the cheaper thing is slightly worse, because I would love that because it's going to increase aggregate overall health, and so that's great. And I suspect that many clinicians in the building would strongly disagree with that perspective. And it's tough to do that once the system's already implemented, which is part of the reason that I think it's important that we have the conversations now about what sorts of things are acceptable inputs, what sorts of things are acceptable models to bring into this process at the beginning, because once it's already developed, once you have that black box, it's really hard to know what's going in it, and it's really hard to say, actually, that thing that's being involved there is unacceptable unless you've thought about it on the front end. Now, part of this is actually already going on, right? So a different area that I didn't talk about is the fact that we're already developing, or hospitals and insurers are already developing machine learning algorithms to say things like, how can we more efficiently bill patients? Like, there are literally machine learning algorithms to identify new codes to bill patients that otherwise the physician might not have noticed, and say, hey, we're gonna analyze all this stuff. Actually, probably we should also bill for this higher code. So there are upcoding algorithms. And things like efficiency in terms of hospital resource allocation, which patients should get this bed, which patients should not get this hospital bed in a situation of constrained resources. Lots of knotty ethical questions that you can hide behind a black box if you don't think of them on the front end and help influence the way they're developed up front. Which again is why I think now is the time to talk about this rather than, hey, this is something we've already been doing for a while, and how do I interrogate this to find out if it's implementing concerns or if it's raising concerns? The answer is you can't. You can't interrogate it now because we've already started doing it. And we don't know how it's working. I think that's my time, right? Thank you very much.